Patients with diabetes can decrease several risk factors associated with macrovascular complications, such as obesity, smoking, hypertension, high fat intake, and sedentary lifestyle. Smoking, which is detrimental to health in general, is especially injurious to people with diabetes and significantly increases their risk of blood vessel and cardiovascular disease, stroke, and lower extremity amputation. The ADA recommends yearly screening for cardiovascular disease risk factors in people with diabetes. Optimizing BP control in patients with diabetes is significant for the prevention of cardiovascular and renal disease. Treating hypertension in those with diabetes results in a decrease in macrovascular and microvascular complications. Hypertension causes an increase in mortality rate among people with diabetes in comparison with those with hypertension without diabetes. A target BP of less than 140/90 millimeters per mercury is recommended for all patients with diabetes. Patients with diabetes have an increase in lipid abnormalities. This contributes to the increase in cardiovascular disease seen in this population. The American Diabetes Association recommends that LDL cholesterol goal of less than 100, triglyceride levels of less than 150, HDL cholesterol levels greater than 40, and greater than 50 in women as target values. The ADA advocates lifestyle interventions, including nutritional therapy, exercise, weight loss, and smoking cessation to treat hyperlipidemia. In patients over 40 years old, and if clinically indicated, statin treatment such as Lipitor is used in addition to lifestyle therapy. In patients under 40 years of age and in those with type 1 diabetes, treatment with a statin, again such as Lipitor, is used if the patient has increased CVD risk factors. Microvascular complications result from thickening of the vessel membranes in capillaries and arterioles in response to conditions of chronic hyperglycemia. They differ from the macrovascular complications in that they are specific only to diabetes. Although microangiopathy can be found throughout the body, the areas most notably affected are the eyes, kidneys, and skin. Microvascular changes are present in some patients with type 2 diabetes at the time of diagnosis. However, clinical manifestations usually do not appear until 10 to 20 years later. Diabetic retinopathy refers to the process of microvascular damage to the retina as a result of chronic hyperglycemia, presence of nephropathy, and hypertension in patients with diabetes. Diabetic retinopathy is estimated to be the most common cause of new cases of adult blindness. Retinopathy can be classified as either non-proliferative or proliferative. The most common symptoms of moderate to advanced diabetic retinopathy is blurred vision and spots. The majority of people in the early to middle phases can be asymptomatic. In non-proliferative retinopathy, the most common form, there's a partial occlusion of the small blood vessels in the retina, which can cause microaneurysms to develop in the capillary walls. The walls of these microaneurysms are so weak that capillary fluid can leak out, causing edema, and eventually something known as hard exudates or intraretinal hemorrhages. This may be mild or cause severe vision loss, depending on which parts of the retina are affected. If the center of the retina, called the macula, is affected, central vision can be lost and be severe. Proliferative retinopathy, the most severe form, involves the retina and the vitreous humerus. When retinal capillaries become occluded, the body compensates by forming new blood vessels to supply the retina with blood. This pathologic process is known as neovascularization. The new vessels are extremely fragile and they can hemorrhage easily, producing vitreous contractions. Eventually, light is prevented from reaching the retina as the vessels become torn and bleed into the vitreous cavity. The patient sees black or red spots or lines. If these new blood vessels pull the retina while the vitreous contracts, they can tear, partially or complete, and cause what's known as a retinal detachment. If the macula is involved, vision is lost, and without treatment, more than half of patients with proliferative diabetic retinopathy will go blind. This slide is just a representation of the difference between non-proliferative and proliferative diabetic retinopathy. So you just see the aneurysms from the microaneurysms, the hemorrhages, the hard exudates, which from the capillary leaks, with this hard exudate is going to be protein and lipid. And then with the proliferative diabetic phase, you're going to see the neovascular, or those weak new blood vessels that have grown in compensation. So you're going to see bigger exudates and you're going to see bigger hemorrhages. The earliest and most treatable stage of diabetic retinopathy often produces no changes in the vision. Therefore, patients with type 2 diabetes should have an eye exam with pupil dilation by an ophthalmologist or a specially trained optometrist at the time of diagnosis and annually thereafter for early detection and treatment. A person with type 1 diabetes should have the eye examined with dilation within 5 years after the onset of diabetes and then repeat the examination annually. The best approach to the management of diabetes-related eye disease is to prevent it by maintaining healthy blood glucose levels and managing hypertension. Laser photocoagulation therapy is indicated to reduce the risk of vision loss in patients with proliferative retinopathy or macular edema, and in some cases of non-proliferative retinopathy. Laser photocoagulation destroys the ischemic areas of the retina that produce growth factors that encourage the growth of the new blood vessels known as neovascularization. The patient who develops vitreous hemorrhage and retinal detachment of the macula may need to undergo an emergent vitrectomy. The vitrectomy is the aspiration of blood, membrane, and fibers from the inside of the eye through a small incision just behind the cornea. Research has identified the importance of vascular endothelial growth factor in the development of diabetic retinopathy. There are certain drugs that can be injected into the eye that block the action of VEG, which are known to produce the neovascularization or those growth of new fragile blood vessels. So this blocking action of the VEG can reduce the inflammation that's currently being studied for their effectiveness in treating retinopathy. Diabetic retinopathy, nephropathy, is a microvascular complication associated with damage to the small blood vessels that supply the glomerula of the kidney. It is the leading cause of end-stage renal disease in the United States and is seen in 20 to 40% of people with diabetes. Risk factors for diabetes-related nephropathy include hypertension, genetic predisposition, smoking, and chronic hyperglycemia. Research has demonstrated that kidney disease can be significantly reduced when near normal blood glucose levels are maintained. Patients with diabetes are screened for nephropathy annually for albumin in the urine and a measurement of the albumin to creatinine ratio and a random spot urine collection. Serum creatinine is also measured. Serum creatinine measurements provide an estimation of the GFR, or the glomerular filtration rate, and thus the degree of kidney function. Patients with diabetes who have albumin in the urine receive either ACE inhibitors or angiotensin II receptor antagonists, such as losartan. Both classifications of these drugs are used to treat hypertension and have been found to delay the progression of nephropathy in patients with diabetes. Hypertension will significantly accelerate the progression of nephropathy. Therefore, aggressive blood pressure management is indicated for all patients with diabetes. Keeping blood glucose levels in a healthy range is also critical for the prevention and delay of diabetes-related nephropathy. Diabetic neuropathy is nerve damage that occurs because of the metabolic derangements associated with diabetes. Approximately 60 to 70% of patients with diabetes will have some degree of neuropathy. Screening for neuropathy begins in patients with type 2 diabetes at the time of diagnosis and 5 years after diagnosis in patients with type 1 diabetes. The pathological process of diabetic neuropathy are not well understood. Several theories exist, including metabolic, vascular, and autoimmune factors. The prevailing theory is that persistent hyperglycemia leads to an accumulation of sorbitol and fructose in the nerves that cause damage by an unknown mechanism. The result is reduced nerve conduction and demyelinization. Ischemia and blood vessels damaged by chronic hyperglycemia that supplies the peripheral nerves is also implicated in the development of diabetes-related neuropathy. Neuropathy can precede, accompany, or follow the diagnosis of diabetes. The two major categories of diabetes-related neuropathy are sensory, which affects the peripheral nervous system, and autonomic neuropathy. Each of these types can take several forms. This can lead to the loss of protective sensation in the lower extremities, and coupled with other factors, this significantly increases the risk for complications that result in a lower limb amputation. The most common form of sensory neuropathy is distal symmetric polyneuropathy, which affects the hands and our feet bilaterally. This is sometimes referred to as a stocking glove neuropathy. Characteristics of distal symmetric polyneuropathy include loss of sensation, abnormal sensations, pain, and paresthesias. The pain, which is often described as burning, cramping, crushing, or tearing, is usually worse at night and may occur only at that time. Paresthesias may be associated with tingling, burning, and itching sensations. The patient may report a feeling of walking on pillows or numb feet. At times, the skin becomes so sensitive, which is known as hyperesthesia, that even light pressure from bed sheets cannot be tolerated. Complete or partial loss of sensitivity to touch and temperature is often common. Managing blood glucose levels is the only treatment for diabetes-related neuropathy. It is effective in many but not all cases. Drug therapy may be used to treat neuropathic symptoms, particularly pain. Tricyclic antidepressants are moderately effective in treating the symptoms of diabetic neuropathy. They work by inhibiting the reuptake of norepinephrine and serotonin, which are neurotransmitters believed to play a role in the transmission of pain through the spinal cord. Duloxetine is thought to relieve pain by increasing the levels of serotonin and norepinephrine, which improves the body's ability to regulate pain. Anti-seizure medications such as Neurontin or gabapentin decrease the release of neurotransmitters that transmit pain. Autonomic neuropathy can affect nearly all body systems and lead to hypoglycemic unawareness, bowel incontinence and diarrhea, and even urinary retention. Gastroparesis or delayed gastric emptying, delayed gastric motility, is a complication of autonomic neuropathy that can produce anorexia, nausea, vomiting, gastroesophageal reflux, and persistent feelings of fullness. Gastroparesis can trigger hyperglycemia by delaying food absorption. Cardiovascular abnormalities associated with autonomic neuropathy are postural hypertension, resting tachycardia, and painless myocardial infarction. Assess patients with diabetes for postural hypertension to determine if they are at risk for falls. Instruct the patient with postural hypertension to change from a lying or sitting position slowly. Diabetes can also affect sexual function in women and men. Erectile dysfunction in men with diabetes is well recognized and common, often being the first manifestation of autonomic neuropathy. ED in diabetes is often associated with other factors including vascular disease, elevated blood glucose levels, endocrine disorders, psychogenic factors, and medications. Decreased libido is a problem for some women with diabetes. Candidal and nonspecific vaginitis are also common. Sexual dysfunction necessitates sensitive therapeutic counseling for both the patient and the patient's partner. A neurogenic bladder may also develop as the sensation in the bladder walls decrease, causing urinary retention. A patient with retention has infrequent voiding, difficulty in voiding, and a weak stream of urine. Emptying the bladder every 3 hours in a sitting position helps to prevent urinary stasis and subsequent infections. Tightening the abdominal muscles during voiding and using something known as Credet's maneuver, which is the mild massaging downward over the lower abdomen and bladder, may also help with complete bladder emptying. Medications known as cholinergic agonists, such as urocholine, may be helpful. The patient may also need to learn self-catheterization. The development of diabetes-related foot complications can be the result of a combination of microvascular and macrovascular diseases that place the patient at risk for injury and serious infection. Sensory neuropathy and peripheral arterial disease are risk factors for foot complications. In addition, clotting abnormalities, impaired immune function, and autonomic neuropathy also have a role. Smoking is deleterious to the health of lower extremity blood vessels and increases the risk for amputation. Sensory neuropathy is a major risk factor for lower extremity amputation in the person with diabetes. Loss of protection sensation, or LOPS, often prevents the patient from being aware that a foot injury has occurred. Improper footwear and injury from stepping barefoot on foreign objects are common causes of undetected foot injury in patients with LOPS. Because the primary risk factor for lower extremity amputation is LOPS, annual screening with a monofilament is important. This is done by applying a thin, flexible filament to several spots on the plantar surface of the foot and asking the patient to report if it is felt. Insensitivity to a monofilament has been shown to gently or greatly increase the risk for foot ulcers that can lead to amputation. PAD, or peripheral arterial disease, increases the risk for amputation by causing a reduction in blood flow to the lower extremities. When blood flow is decreased, oxygen, white blood cells, and vital nutrients are not available to the tissues. Wounds take longer to heal, and the risk for infection increases. Since PAD includes something known as intermittent claudication, pain at rest, cold feet, loss of hair, delayed capillary filling, and dependent rubor, which means redness of the skin that occurs when the extremity is in a dependent position. Management includes reduction of risk factors, particularly smoking, cholesterol intake, and hypertension, graft surgery, is sometimes needed in these patients. If the patient has LOPS or PAD, aggressive measures must be taken to teach the patient how to prevent foot ulcers. These measures include the selection of proper footwear, including prescription shoes. Other measures are to carefully avoid injury to the foot, practice diligent skin and nail care, inspect the foot thoroughly each day, and treat small problems promptly. Proper care of a foot ulcer is critical for wound healing. Several forms of treatment can be used for the management of foot ulcers. Casting can be done to redistribute the weight on the plantar surface of the foot. Wound care for the ulcer can include the debridement, dressings, advanced wound healing, a vacuum-assisted closure like a VAC, ultrasonography, hyperbaric oxygenation, and skin grafting. A person with diabetes is more susceptible to infections. This is due to a defect in the mobilization of inflammatory cells and impaired phagocytosis by neutrophils and monocytes. Recurring or persistent infections such as Candida albicans, as well as boils and furnicles in patients with undiagnosed diabetes often lead the physician to suspect diabetes. Loss of sensation may delay the detection of an infection. Persistent glycosuria, or glucose in the urine, may predispose patients to bladder infections, especially in patients with a neurogenic bladder. Decreased circulation resulting from angiopathy can prevent or delay the immune response. Antibody therapy has prevented infection from being a major cause of death among patients with diabetes. The treatment of infections must be prompt and vigorous. Teach patients measures to prevent infection. People with diabetes should practice good hand hygiene and avoid exposure to individuals who have communicable diseases or illnesses. An annual flu vaccine is advisable, and in addition, the pneumovax is recommended. Patients with diabetes have high rates of depression, anxiety, and eating disorders. Depression contributes to diminished diabetes self-care, feelings of helplessness related to chronic illness, and poor outcomes. Assess patients for manifestations of depression and or diabetes distress. Disordered eating behaviors can occur in patients with both type 1 and type 2 diabetes. These include anorexia, bulimia, binge eating, excessive restriction of calories, and intense exercise. The greatest incidence of eating disorders is seen in females. Adolescent girls with diabetes are more than likely to develop DEB than those who do not have diabetes. Patients may intentionally decrease their dose of insulin or omit the dose. This is called diabulimia and leads to weight loss, hyperglycemia, glycosuria, because the food ingested cannot be used for energy without adequate insulin. Insulin omission and DEBs can have serious consequences, including retinopathy, neuropathy, lipid abnormalities, DKA, and death. Open communication is critical to identify these behaviors early. People with eating disorders need to be seen by a mental health professional with expertise in eating disorders and an understanding of diabetes management. Diabetes is present in more than 25% of persons older than 65, and this age group is the fastest growing segment of the population developing diabetes. The prevalence of diabetes increases with age. A major reason for this is that the process of aging is associated with a reduction in B cell function, decreased insulin sensitivity, and altered carbohydrate metabolism. Older people with diabetes have higher rates of premature death, functional disability, and coexisting illnesses such as hypertension and stroke than do those with diabetes. One reason is that hypoglycemic unawareness is more common in older adults, and so these patients are more likely to suffer adverse consequences from blood glucose lowering therapy. They may have delayed psychomotor function that could interfere with the ability to treat hypoglycemia. Other factors to consider in establishing glycemic goals for an older patient include the patient's own desire for treatment and other coexisting medical problems such as cognitive impairment. Compounding the challenge, diabetes increases the rate of decline of cognitive function. Although it is generally agreed that a level of treatment is indicated to prevent complications, intensive diabetes management may be difficult and dangerous to achieve, especially in older patients. Meal planning and exercise are recommended as therapy for older adults with diabetes. This therapy should take into account functional limitations that may interfere with physical activity and the ability to prepare meals. Because of the physiologic changes that occur with aging, the therapeutic outcomes for the older adults with diabetes who receive OAs may be altered. We need to assess renal function and creatinine clearance in patients older than 80 who are taking metformin. Monitor those taking sulfonylurea drugs such as glycoside for hypoglycemic and for renal and liver dysfunction. Insulin therapy may be instituted if oral agents are not effective. However, it is not important to recognize that older adults are more likely to have limitations in manual dexterity and visual acuity necessary for accurate insulin administration. Insulin pens may be a safer alternative for older adults. Patient education issues for the older patient include those related to altered vision, mobility, cognitive status, and functional ability. Plan patient teaching based on the individual's needs. For patients with cognitive and functional limitations, use a slower pace with simple printed or audio materials. It is important to include the patient or family caregiver in the teaching. Consider the patient's financial and social situation, as well as the effect of multiple medications, eating habits, and quality of life issues.